The American healthcare system is broken. Here is how we actually fix it. An article by B-Ski Mike, The Woman on the Ladder. Her name does not matter for the story. What matters is what happened to her. She is 64 years old. She climbed a ladder, something she had done 1,000 times in her life, and she fell hard. Both ankles fractured on impact. Soft tissue damage in both knees, so severe the surgeons later said it looked like her legs had been fed through an industrial compactor. Bilateral femur fractures, a shattered pelvis, and then before anyone could fix a single bone, the internal bleeding started. She almost died on that operating table. Multiple emergency surgeries, hours under anesthesia. Specialists cycling in and out of her room like a revolving door of very expensive, very well-meaning people who each owned exactly one small piece of an enormous, impossible puzzle. She fought, she survived, and then the system really kicked her. The insurance company approved a transfer to a rehabilitation facility that, and I need you to sit with this for a full second, was not equipped to handle the complexity of her rehabilitation needs. Not even close. Bilateral lower extremity fractures with pelvic involvement requires specialized physical therapists, occupational therapists who understand multi-level trauma, and a coordinated care plan executed by people who've actually seen this kind of case before. What she got was a facility that approved the bed, billed the insurer, and parked a very broken human being in a room, and called it rehabilitation. Why did this happen? Because the insurance company approved what was cheapest, not what was correct. Because the system is so immense, so bloated, and so thoroughly removed from the actual human being lying in that bed, that nobody, not the hospital discharge planner, not the insurance case manager, not the billing department processing her file, was making decisions based on what she needed. They were making decisions based on what the system would pay for. The system is too big to care about patients. Let that sentence sit right where it is. I will come back to it. The other story, because one is never enough. A 47-year-old construction worker, father of 3, the kind of guy who showed up every single day, was diagnosed with type 2 diabetes about 6 years ago. Manageable, with the right care. His doctor wanted quarterly labs, wanted to see him every 90 days, said it was important. His insurance denied the quarterly visits. Too frequent, they said, not medically necessary. So he went twice a year instead, because that is what they approved. Within 3 years, diabetic neuropathy in both feet, a non-healing wound on his left foot, an infection, a below-the-knee amputation. Tell me again how the quarterly visits were not medically necessary. Tell me again how the system that denied $150 appointments, but then paid $80,000 for an amputation and $40,000 in rehabilitation is being efficient. Tell me with a straight face that it is working. This is not an edge case. This is American healthcare in 2026, playing out in hospital rooms and rehab facilities and doctors' offices across this country every single day. And before I give you the solution, because I actually have one, unlike most of the politicians who have been working on this since before I was patching up wounded soldiers, you need to understand how we got here, because the answer tells you everything about what has to change. How the greatest medical system in the world broke itself. In 1930, Americans spent $2.8 billion total on healthcare, $23 per person, 3.5% of gross domestic product. Medicine was relatively simple, but it was also relatively cheap, and there was a very logical reason for that. The person receiving the care was the person paying for it directly. No middleman, no bureaucracy. You, the doctor, and a bill you could actually read. The system started breaking in the 1940s. And here is the irony that should make your head explode. It broke because of something that looked at the time like an act of generosity. During World War II, the federal government imposed wage controls. Employers could not attract workers by raising pay. So they started offering health benefits instead. The Internal Revenue Service ruled those benefits tax exempt. One administrative ruling, made without any particular forethought, locked American healthcare permanently to your employer. Not to you, to your job. If you left, you lost it. If you got fired, you lost it. If you started your own business, you lost it. Think about what that means. Your health became a benefit that someone else controls. You cannot customize it, you cannot take it with you, and you are structurally a hostage to whatever plan your employer negotiated with, whatever insurer offered the best deal that year. It is a bizarre arrangement that exists in basically no other wealthy country on earth. And it happened by accident. Or did it? Then came 1965, Medicare and Medicaid. I'm not going to pretend those programs had no value. They brought millions of elderly and low-income Americans into coverage who had nothing. That part matters. But both programs adopted an open-ended reimbursement model. Pay whatever the provider charges, essentially. No meaningful cost controls, no incentive to restrain. And since the federal government was suddenly a massive buyer, hospitals and physicians learned quickly that you could charge more and get paid more with almost no pushback. The system absorbed that lesson and never let it go. The 1980s brought managed care health, maintenance organizations, gatekeeping, utilization review, sold to the public as cost control. It worked briefly in the mid-1990s. Then patients revolted because they hated being told they needed a referral to see a specialist. The insurers backed off and costs resumed their climb. By the late 1990s, 44 million Americans were uninsured. Then, and here's where Jim Quinn's first law of liberalism applies with almost textbook precision. The government decided to fix what the government had broken by adding more government. Quinn's first law. Liberalism always generates the exact opposite of its stated intent. The Affordable Care Act of 2010, some of it was genuinely good, ending pre-existing condition discrimination, keeping young adults on parents' plans, eliminating lifetime caps. None of that was wrong. But the Affordable Care Act did not fix prices. It did not reform fee-for-service. It did not attack the administrative bloat that was already consuming 25 to 30 cents of every healthcare dollar. The Affordable Care Act was supposed to make healthcare more affordable. Per capita health expenditures in 2010 were roughly $8,400. By 2024, they hit $15,474. The average household now spends 38% more on health insurance than the pre-Affordable Care Act trendline projected. Costs went up. The law called the Affordable Care Act made healthcare less affordable. Quinn's law, right on schedule. And here's what the insurance companies did in response to the Affordable Care Act's requirement that they spend 80 to 85% of collected premiums on actual medical services. They started buying doctor practices and hospital systems. United Health Group now directly employs 10,000 physicians and has commercial ties to 80,000 more. That is 10% of all American doctors. When your insurer also employs your doctor, whose side do you think that doctor is structurally incentivized to be on? By 2024, total American healthcare spending hit $5.3 trillion. That is 18% of our entire gross domestic product. We are spending nearly a fifth of everything this nation produces on healthcare, and we rank last among high-income countries for actual health outcomes. Last. Behind countries that spend half what we spend. The administrative overhead, the billing, the coding, the prior authorizations, the denial appeals, the compliance layers consumes 25 to 30% of every dollar. Not care, not treatment, paperwork. Still, nobody in Washington could propose anything more useful than arguing about which version of the subsidy extension to pass before the next government shutdown. When the system produces a reaction, I am going to say something that will make some people uncomfortable. Stay with me. When United Healthcare Chief Executive Officer Brian Thompson was shot and killed in Midtown Manhattan in December of 2024, the public reaction was not grief. It was, to an enormous and deeply disturbing degree, dark celebration. Nurses posted memes. Reddit threads overflowed with grim satisfaction. People who had been denied claims, who had watched family members fight for procedures their doctors prescribed, who had gone bankrupt paying bills they thought their insurance would cover, reacted to a man's murder with something closer to relief than horror. Murder is wrong. Full stop. No policy grievance justifies it. But here is what that reaction tells us, and what the political class needs to hear before more people decide that a 26-year-old with a ghost gun is the only complaint form the system responds to. When a country full of people cheer an execution, it is not because they are evil. It is because they are exhausted. Exhausted from fighting denials. Exhausted from watching a father lose a foot because quarterly labs were classified as not medically necessary. Exhausted from reading that, United Healthcare denied 1 out of every 3 claims while posting $22 billion in profit in a single year. The system produced that reaction. The system. And the left, predictably, responded to that anger by pushing for single-payer healthcare, which would take the same bureaucratic, patient-ignoring, denial-issuing logic and hand it to the federal government to operate at a scale that makes United Healthcare look like a neighborhood urgent care clinic. That is not a solution. That is a sequel nobody asked for. The answer is not to hand the broken machine to Washington. The answer is to replace it with something that puts the patient, not the insurer, not the hospital system, not the government agency, at the center of every single decision. So here is what that looks like. the American health freedom system. 3 pillars. Each one exists right now, today, working in real practices and real businesses with real outcomes that are documented and verifiable. This is not a think tank white paper. It is a framework built from things that are already working, scaled to cover 330 million Americans. Pillar 1, direct primary care. Direct primary care, or DPC, if you want the shorthand, is the most important concept in this entire proposal. Most Americans have never heard of it. That tells you everything about how badly the medical political complex wants things to stay exactly as they are. Here's how it works. You pay your primary care doctor a flat monthly membership fee, typically $50 to $100 per adult, less for children. In exchange, you get unlimited primary care, same day or next day appointments. Visits that last 30 to 60 minutes, rather than the 8-minute medical drive-through that modern insurance-based practices produce. Your doctor actually knows your name, your history, your family, the things that actually matter when you are sick. The doctor does not bill insurance for primary care, at all. No billing department, no prior authorization calls, no denial appeals. The practice employs 2 or 3 people instead of 15. The doctor sees 1,500 patients instead of 3,000, has time to think about each one, and went into medicine to actually help people rather than to spend half the day on the phone arguing with an adjuster who spent 1.5 seconds reviewing a claim before clicking deny. Labs at wholesale cost. We are talking $10 to $50 for panels that generate $400 bills in a traditional office. Common medications at cost plus a small margin, not the insane retail markups built into a pharmacy benefit manager system that nobody outside the industry can fully explain or justify. Employers who adopted direct primary care programs have seen total medical spending drop 20 to 52%. Emergency room visits fall 17 to 73%. Hospital admissions drop 20 to 40%. Over 7,200 employers were doing this as of 2025 to 2026, with documented results. The data exists. It is simply being ignored by a political system that profits from the complexity it creates. Pillar 2, catastrophic coverage. Direct primary care handles your routine care. Everything from chronic condition management to sick visits to preventive screenings to your kid's checkup. What it does not handle is the moment the ladder breaks under you and you fracture both ankles in your pelvis and start bleeding internally. That is what true catastrophic insurance is for. Not the bloated, covers everything, $2,000 per month comprehensive plan that exists primarily to generate insurer profit. Real catastrophic coverage. A high deductible major medical plan that activates for hospitalizations, surgeries, cancer treatment, emergency care, the events that genuinely threaten to bankrupt a family. A healthy 35-year-old paired with direct primary care can get a solid catastrophic plan for $200 to $350 per month. A family of 4, roughly $600 to $1,200 per month. Add in the direct primary care membership, and the total monthly healthcare outlay for a family is often $750 to $1,500 compared to $1,500 to $2,500 or more in premiums alone under traditional comprehensive coverage before a single deductible dollar has been paid. Because direct primary care is actively keeping you healthier, catching things early, managing chronic conditions before they become catastrophic events, the catastrophic plan gets used far less frequently. That is the economic logic. Prevention is cheaper than amputation. It should not require a science teacher to say that out loud, but here we are. For lower-income Americans, premium tax credits and income-scaled vouchers cover direct primary care membership fees and catastrophic plan premiums. Nobody falls through the floor. The safety net is maintained, just maintained more efficiently, with less bureaucratic friction, and without the spectacular administrative waste that currently consumes 25 to 30 cents of every dollar before a single patient is actually treated. Pillar 3, health savings accounts with $1,000 at birth. Here's the part that should genuinely excite every American who has ever complained about the national debt while simultaneously worrying about what retirement healthcare costs are going to do to them. The health savings account. Triple tax advantaged. Contributions go in tax-free, they grow tax-free, they come out tax-free for qualified medical expenses. Post 65, you can withdraw for anything you want and just pay regular income tax, functionally making it a second individual retirement account specifically designed for the single most expensive category of spending in most American retirements. In 2026, you can contribute up to $4,400 as an individual, or $8,750 as a family. A family in the 24% tax bracket who maxes their health savings account saves $2,100 in federal taxes that year alone, before a dollar of compounding growth. This is real money. For a family feeding 6 on a teacher's salary, $2,100 is real. Now here is the part President Trump got exactly right with the concept of Trump accounts. And here is how we apply it specifically to healthcare. Every American child at birth receives a $1,000 federal deposit into a dedicated health savings account. Every single one. That $1,000 invested in a low-cost, broad market index fund at a conservative 7% annual return grows to approximately $81,000 by the time that child turns 65, with no additional contributions. Just the $1,000 deposited the day they were born, left alone for 65 years. The federal government would fund roughly 3.6 to 4 million birth deposits per year. Total annual cost, $3.6 to $4 billion. That is 0.07% of what we currently spend on healthcare. For reference, that is less than what investigators identified in potential Medicaid fraud from shell companies operating out of a single Columbus, Ohio address. We have the money. We have been hemorrhaging it in the wrong direction. Every American child born from the day this law passes owns, from birth, a portable, permanent, individual health account that follows them through every job change, every life transition, every economic circumstance. Theirs, not their employers, not the government's, theirs. That is healthcare freedom, not a government program that can be cut when the political winds shift. Personal ownership of your own healthcare future, seated at birth and compounding for a lifetime. What this looks like in actual numbers. A healthy individual in their 30s under the American Health Freedom System, direct primary care membership, $75 per month. Catastrophic plan, $250 per month. Total monthly healthcare outlay, $325. Under traditional comprehensive coverage today, $500 to $800 per month in premiums alone, before the first copay, the first deductible dollar, the first billing dispute, a family of 4. Direct primary care at $250 per month. Catastrophic high deductible health plan at $900. Total, $1,150. Under current employer comprehensive coverage, many families pay $1,800 to $2,500 or more per month in total premiums, and still face a $6,000 family deductible before the plan actually does much. Lab work in the direct primary care model, $10 to $50 instead of hundreds. Generic medications, wholesale, often pennies on the dollar. Specialist referrals. Fewer needed because primary care catches things earlier. And when a specialist is needed, the direct primary care doctor coordinates the referral personally because they know the patient and because their model rewards keeping people healthy rather than billing them for another short visit. For the 64-year-old woman who fell off the ladder, under this model, her direct primary care physician has been managing her health for years. He or she knows her bone density, her activity level, her risk factors. When the fall happens and the acute care is needed, the catastrophic plan covers the hospitalizations and surgeries. And when rehabilitation is required, her direct primary care physician is coordinating the transfer, not a discharge planner, working from a list of approved beds to a facility that can actually handle what she needs. For the construction worker with diabetes, quarterly visits, not because an insurer approved it, because his $75 monthly membership includes it and his doctor recommends it. He keeps his foot. His family keeps him whole, with a history lesson nobody in Washington wants to give you. On January 10th, 1963, Congressman Albert Herlong read a list of 45 communist goals for America into the congressional record, not my invention, the congressional record. Goal 27, infiltrate the courts to make judges more liberal and thus undermine the authority of the judiciary. Goal 32, support any socialist movement to give centralized control over any part of the culture, education, social agencies, welfare programs, mental health clinics, etc. When the left pushes for Medicare for all, a single-payer system where the federal government controls every dollar flowing through the entire healthcare economy, they are not proposing something novel. They are describing what Goal 32 outlined as an objective 60 years ago: centralized control. Government as the singular decision maker, the same entity that allowed $66 million in documented fraudulent Medicaid billing from 93 shell companies at a single Columbus, Ohio address, deciding whether your 64-year-old mother gets transferred to the right rehabilitation facility. No, I will decline that arrangement. Quinn's Law number 5. When liberalism conflicts with reality, Reality must give way. The reality is that every country with a government-run single-payer system rations care through wait times, approved treatment lists, and the quiet math of who gets the expensive procedure and who gets told to manage their symptoms. The United Kingdom had 7.4 million people on National Health Service waiting lists as of 2023. Canada's average wait for specialist treatment is 27.4 weeks. The United States has the highest 5-year cancer survival rates in the world, the best outcomes for serious disease if you can access care. The problem is not the quality of care available here. The problem is that the delivery system has been so thoroughly optimized for insurer and hospital system profit margins that patients are going bankrupt accessing it. You do not fix that by handing the whole thing to the federal government. You fix it by stripping out the bureaucratic friction, empowering patients with their own accounts, and letting doctors be doctors again. And by the way, about those Affordable Care Act subsidies. Since the subject comes up every single time anyone discusses healthcare costs, let me be precise about who is responsible for rising Affordable Care Act premiums. The COVID-era enhanced Affordable Care Act subsidies were created by the American Rescue Plan Act of 2021 and extended by the Inflation Reduction Act of 2022. Not a single Republican voted for either bill. Democrats wrote those subsidies. Democrats made them temporary. Democrats placed an expiration date in the legislation with full knowledge that it was there. When those temporary subsidies expire and premiums rise to reflect their actual cost, the people responsible are the ones who voted for a time-limited measure and then acted surprised when the time limit arrived. Here is the analogy I use with my students, because I am a teacher and I use analogies. Imagine your boss gave you a $1,000 Christmas bonus last December. This December, the bonus did not appear. You march into his office and say, "You cut my pay by $1,000. That is not a pay cut. That is the end of a bonus. You cannot receive a temporary benefit, build your household budget around it, and accuse someone else of theft when the temporary period expires." That is the Democrat argument on Affordable Care Act subsidies, word for word. It is economically illiterate, and it is deliberately designed to obscure who made the decisions that led here. Quinn's Law number 6. Facts are the enemy of liberalism. This particular fact makes a lot of people in Washington very uncomfortable. The plan, in plain English. No jargon, no 2,000-page bill, no subsystem of subsidies that creates a new bureaucracy to fix the one the last bureaucracy broke. 1. Every American gets access to a direct primary care physician for a flat monthly membership of $50 to $100 per adult, subsidized by tax credits for lower incomes. No insurance billing for primary care, ever. The doctor-patient relationship restored to what it was always supposed to be. 2. Every American carries true, catastrophic, major medical coverage for the events that can genuinely destroy a family financially. Premium subsidies, scaled by income, replace the current patchwork of Affordable Care Act marketplace complexity. Insurers compete on price and service. No more monopolized regional markets where 3 companies cover 90% of the area and price accordingly. 3. Every American child receives a $1,000 federal deposit into a health savings account at birth, invested in low-cost index funds, growing tax-free for their lifetime. Health savings account contribution limits expanded. Direct primary care membership fees confirmed as health savings account eligible expenses. Every American owns, personally, a portable, tax-advantaged healthcare account that belongs to them and follows them everywhere they go. 4. Price transparency mandated for every provider, every procedure, every drug, in plain English, publicly searchable, enforced with actual consequences for non-compliance. You cannot have a functional market without pricing information. This is Economics 101. 5. Real antitrust enforcement against hospital, insurer, and private equity consolidation that has turned healthcare into a series of captive markets where patients have no leverage. When private equity firms control more than 30% of a local healthcare market, prices rise 13 to 18% with no corresponding improvement in outcomes. That is a cartel. Treat it like one. 6. Malpractice reform so that direct primary care physicians practicing evidence-based medicine have safe harbor protections. And so that the epidemic of defensive medicine ordering tests, not because they are clinically necessary, but because they reduce lawsuit risk, is addressed, rather than quietly subsidized by every patient who pays a bill. The closing argument. I am a high school anatomy and physics teacher in a high-need career technical district in Northeast Ohio. I feed a family of 6 on a teacher's salary. I know the specific grinding anxiety of looking at a healthcare premium bill and wondering how you cover it. And also buy groceries. I was a civilian paramedic. I sat in ambulances with people at the worst moments of their lives and watched what happened when the system they were about to enter was not oriented toward their well-being. I was a combat medic. I have seen what a system optimized for institutions instead of people does to the individuals trapped inside it. I saw it in a combat zone. I see it every time an insurance company denies a $150 quarterly diabetes check and then pays $120,000 for an amputation instead. The politicians on both sides have had decades to fix this. They have not fixed it because the current system generates enormous amounts of money for the people and institutions that fund their campaigns. Quinn's Law number 1, inaction. Again, exactly as predicted. Direct primary care, catastrophic coverage, health savings accounts with $1,000 at birth. 3 pillars, proven, scalable, patient-centered, not theoretical. Every pillar is working in real practices and real employer programs right now with documented outcomes. All we lack is the political will to scale what already works and dismantle what has demonstrably failed. The 64-year-old woman deserved to land in a rehab facility that could actually rehabilitate her. The construction worker deserved his quarterly labs. Every American child deserves to be born into a healthcare system that was built to serve them. We can build that system. The technology is there, the economic logic is overwhelming, the evidence is stacked in one direction. All we need is leadership that cares more about patients than it cares about the institutions that profit from their suffering. If this article made you think, like it, so the algorithm shows it to people who need to read it. Share it. Every share genuinely helps get the word out. Comment below with your take. Have you been failed by the current system? Have you used a direct primary care practice? Tell me. And if you want more of this, the data, the history, the science, the stories, join Beeskey's classroom community or follow on YouTube. Even better, subscribe. It is about the cost of a cup of coffee per month. That is it. Your support keeps this classroom open. But what do I know? I am only a science teacher, a published author, a former Army combat medic, and a paramedic who has watched this broken system fail real people in real time and decided that somebody ought to write down a better idea.